Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Today, in episode 2 of our 2-part series on the consequences of restricting abortion, we'll look at the unintended reach of the Dobbs decision overturning Roe v. Wade. Dr. Daniel Grossman is an obstetrician and gynecologist, and Dr. Katrina Kimport is a sociologist in the Department of Obstetrics, Gynecology, and Reproductive Services at the University of California at San Francisco. They are 2 authors of a recent study that described what is happening to patients in states that have put in place severe restrictions on access to abortion care over the last year. If you missed part 1 in this series, check out episode 656 about new research that puts numbers to the question of how many additional live births occurred in Texas in 2022 as a result of abortion restrictions that passed in 2021. Please note that this podcast today contains content about pregnancy, abortion, miscarriage, and stillbirth. Let's listen.
Dr. Daniel Grossman, Dr. Katrina Kimport, thank you so much for joining me on Public Health on Call to talk about this study that both of you were deeply involved in. Dr. Grossman, you are an obstetrician gynecologist. Can you talk about the reason why you wanted to do this study?
Sure. Thanks so much, Josh, for having us on the podcast. With the Dobbs decision, there started to be reports in the media about how these restrictions on access to abortion care were having a broader impact beyond just people who were seeking abortion care, but were also affecting people who had complications during pregnancy and other medical conditions. It seemed really important to document those cases. And at the same time, we were also hearing reports about doctors being told by their employers, by the hospitals where they work, not to talk to the media. And so we wanted to, through this study, create an opportunity for clinicians and other members of the healthcare team to submit information about these cases anonymously if they wanted to, so we could document what was happening and what the impact was of these restrictive policies.
Now, Dr. Kimport, you are a sociologist. So beyond the medical details of what may have gone wrong, what were you interested in?
Well, thanks first for having me. I'm really delighted to be part of this podcast. So, of course, there's the medical component that I think a lot of listeners will be interested in. As a sociologist, I came into this study because I'm really interested in the way that policies and practices actually matter on the ground for individual people's lives. And so there was sort of an assumption in general that when Dobbs happened, supporters and opponents of abortion rights both believed that a lot of the effect would be on people who wanted an abortion for an unwanted pregnancy. But I already knew from clinicians that that was probably not going to be where the effects of this change stopped, and that there were probably going to be many more implications. And so I was interested in participating in this study to really understand the breadth, the scope, and the broad implications of something like Dobbs on the lives of people that the general public just doesn't actually think are going to be implicated.
Including the lives of clinicians.
Absolutely, yes. So we found a lot of discussion of the things that were happening to patients. We also really got a sense from clinicians about what it meant, what we might call the moral distress, what it means when you're trained, you have expertise to offer a certain kind of care, and you're prohibited from doing so. And you have to watch your patients get sicker before you can take care of them.
Let's dig into some of the details. Dr. Grossman, could you give an example of a class of cases that was reported to you as part of this study?
Sure. So we launched this study at the end of September of last year. And during the first 6 months of the project, we received 50 submissions, 50 narratives of different kinds of cases. One broad category involved medical complications that were experienced by the pregnant woman. So one example of those kinds of complications involved a woman who was pregnant before viability in the second trimester, whose bag of water broke, who experienced preterm premature rupture of membranes. So at this stage of pregnancy, there's a very high risk of developing an infection, and it's unlikely that the pregnancy is going to continue to a point where the fetus could survive. We received several submissions where the patient came into a facility, was evaluated, rupture of membranes was confirmed, and unlike the usual standard of care, the patient was not offered the option of having an abortion and was sent home and told to come back when they either were in labor or when they had developed signs of an infection. And in several cases, patients developed very serious infections with sepsis and admission to the intensive care unit. There's one case that really stands out in my mind where patient developed sepsis, delivered the fetus spontaneously, but required a procedure to remove the placenta. She developed a coagulopathy where she was bleeding heavily, had many medical complications. And after everything that she went through, the patient then asked the physician, would this situation be considered life-threatening enough, or is there a possibility that you or I could go to jail?
Even after all that?
Even after all of that.
Yeah, I mean, it's been a while since I've been in medical school, but I remember the potential scenario of an infected pregnancy to be absolutely catastrophic.
Yes, it really is. And that's why the standard of care is to counsel patients extensively about that risk and to offer them the option of having a termination. And that's no longer possible in many of these settings.
Dr. Kimport, I want to turn to you because this is a case where I imagine the pregnancy may be wanted.
Yes, our data is coming from clinicians. We aren't actually talking to these patients, but based on their accounts, many of these cases, this is somebody who wants to be pregnant, who hopes to continue the pregnancy. And some of what their accounts reveal is the heartbreakingly large number of ways that pregnancy can go wrong. And so for somebody who's experiencing that, whose wanted pregnancy is unhealthy, is not going to last, and then to layer on top of that sort of emotional trauma, having to get sicker, having potentially a risk of future infertility because of having to get sicker and the clinical investment that needs to go into that. And then to also fear criminalization, that they're doing something that might land them or their caregivers in jail. When we try and imagine what that must be like, to me, it's overwhelming.
What was it like for the clinicians? How did they come to report this? Did they report it matter-of-factly? Did they report it with a great deal of stress? What was their affect?
I think what you're picking up on is, so we did have the reports that came in online. And so some of those absolutely came in a very clinical term, writing in a medical record, and some were more narrative with more emotional components. I also did follow-up interviews with a subset of the people who submitted their cases. So I got to hear in their own voices and their own words. And it ran the gamut. Like some people were fairly clinical reporting things, but then they would have pauses for emotion. There were times when they broke down, and some of the things they talked about was that they didn't feel like they could continue to provide care in the community that they were invested in because their hands were tied. They couldn't offer the care they wanted to. So several of the people I talked to talked about either planning to move to another place to offer obstetric care, or if they were staying in their community, discouraging other people who might come from working in that community because of these restrictions.
Wow.
If I could maybe just add one thing to that. I think in addition to talking about how their hands were tied, they also talked in some of their narratives about how this was just a tremendous amount of additional work that they had to do, not only just caring for these patients, but then trying to arrange for their care sometimes in another state and using their own personal networks by communicating on secure messaging apps to try to find the nearest place where they could send a patient to get care. And this is just not something that they had to do before. And it was taking time away from the care that they would otherwise have been providing to other patients. And this has just, I think, compounded the stress that they were experiencing.
They did that in part because they feared for their patients' lives.
Yep.
Dr. Grossman, could you give us another class of reports that you got?
Yeah, another category involved cases where there were medical complications with the fetus. So this is where the woman was pregnant with a fetus with a severe malformation. Generally, these were described as being incompatible with life. And whereas before Dobbs, patients could have received an abortion in these cases. Now, this was no longer possible. The women were faced with the very difficult choice of either traveling long distances to obtain an abortion in another state, and along with all the financial costs associated with that, or continuing to carry a pregnancy that may have been very much wanted, but they were now being forced to continue this pregnancy until they delivered when they knew that their baby couldn't survive. There was one case that really stands out where the physician just talked about how the counseling of these patients had just gotten so much more complicated because they had to explain how far they were going to have to travel, the potential costs involved, the fact that the patient's partner may not be able to come in with the patient during the procedure. They were going to have to arrange for childcare for their other children. There was also a potential risk that maybe in one case, someone had mentioned to the husband that maybe the husband could be accused of essentially aiding and abetting her abortion, and he could somehow be charged for that. And after going through all this counseling, this physician recounted this one case with the patient said, it's really easy for you to tell me all this, but this is essentially no choice. There's just no way that I could do this.
Dr. Kimport, what context can we have to understand the stress that this may cause? I'm almost speechless imagining that kind of conversation.
I think that one of the most basic takeaways of this is the way that they're universally across people who have a variety of opinions or personal beliefs on abortion. These are cases that people agree that somebody should be able to get standard medical care. And we've even heard politicians who are really outspoken against abortion rights suggesting that the law shouldn't apply to these cases. And so when we think about how do we understand that it is applying to these cases, illustrates the way that these ideas of medical exceptions, they just don't work in practice, right? That the exceptions are written in the law in a black and white way. And then when we get down into actually talking about medical care, it's a lot of gray and it just doesn't translate.
And it sounds like the threat of criminal charges, being put in jail, has this very profound effect, not only on the clinicians, but also on the patients and their families trying to think about what to do.
I think one of the things that is really interesting about this that is maybe different than the way that a lot of abortion restrictions in the past worked is that people were in these accounts, the patients are very aware that their care is being compromised because of these state abortion bans. And I think that in the past, there was sometimes confusion from abortion patients subject to various restrictions about who was making them and who was implementing them. But in these cases, it's really clear what the cause is, and then we're documenting some of the myriad and devastating impacts.
Dr. Grossman, any other example cases you want to mention?
I mean, there are many other cases. I guess one other broad category were situations that really should not be affected by abortion bans, including things like when a patient had a spontaneous miscarriage. So, for example, there was in one case, a woman couldn't get the medication that she needed to treat her miscarriage because a pharmacist was concerned that it was being used to induce an abortion. There were other cases that were unrelated to pregnancy even was disrupted related to these laws. So, for example, there was a patient who was scheduled for a liver transplant after there was a donor match that was identified. And then as part of her preoperative workup, it was found that she had a very early unwanted pregnancy and the transplant was canceled. And that really differs from the usual standard of care. Usually in these cases, the transplant would proceed either with the abortion being done immediately before or after. So again, these were cases where it was unrelated to abortion care. The care was disrupted.
Affecting parts of medicine far outside your field, another way to say that.
Yep.
Dr. Kimport, you started by talking about how these policies may be put in place for one reason and then have very far-reaching implications, and not just at a policy level, but at a personal level for patients, for clinicians. What do you hope people get from a study like this?
I think that one of the takeaways, one of the basic things I think that's really clear from this sort of data is that abortion care is a really important tool in reproductive health care. So that trying to talk about it as separate or distinct and something that can be carved out, in practice, it doesn't work. And so when we think about what the implications are, understanding too, the way that abortion is understood as an idea is not the way that people actually experience it. That the way that this filters into people's lived experience is much more substantial. and worthy of us paying attention to, and then trying to circle back to make better policies that don't have these kinds of negative impacts.
I wish everyone involved in the abortion debate could just have a timeout and read your paper. But in lieu of that, maybe they'll listen to the podcast, or at least some of them. Dr. Katrina Kimport, Dr. Daniel Grossman, this has really been a tremendous discussion. Thank you both.
Thank you for having us.
Thank you very much.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.